I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is the sacred doctor-patient relationship. The doctor-patient relationship used to be a sacred one before it became the financial one that we all know today, before it became this transactional, reactive form of medicine. Today, Robert can't join us. Robert, hope everything's okay, and I look forward to having you back again, hopefully next week. Dr. Dan.
Hey, Faisel.
How are you?
I'm great. I'm great. How are you this evening?
I'm good. I'm glad you're here. I was worried that you may or may not be able to join because of the weather situation in Richmond.
That's right. That's right. Have a little bit of ice, but that's okay. I will stay inside. It's a good night to be inside with you.
Oh, it's great. And this topic is a topic that we often talk about when we're just talking shop, about just the nonsense that patients have to go through, and not even the medically complex. I mean, that is in itself, unforgivable, what patients with actual chronic medical conditions have to go through when they're trying to navigate through their complicated healthcare delivery system. But even people who just need a physical, a checkup, how difficult it is to go just get basic checkups done. This week's friend is someone I'm really excited to have come on, Dr. Jon Hart. Dr. Hart.
Hey, Faisel. Hi, Dr. Dan.
How are you doing tonight?
Doing well. Much warmer than it is up there in Virginia for Dr. Dan, that's for sure.
And you're in South Florida, right?
I'm just probably 100 miles south of you in Fort Myers. Yeah.
Oh my God, that's great. I had the pool heater on earlier, and my kids and my father are all in the pool right now as we speak, just enjoying the weather in Florida. But Dr. Hart, I wanted to ask you about your book, Value in Healthcare, and what was it? What was the main driver? If you had to pick the main one or two drivers for you to write this book, what was it, and where do you feel like you are now?
Yeah, well, that's a great question, Faisel. I think the couple of things that really drove me to write that book were looking in on and working in the healthcare arena where, for the last 40, 50 years, we've been steeped in a volume-based fee-for-service model of healthcare. And I had learned a different way of doing that when working for a health insurance company, believe it or not. And we called that system value-based healthcare, but it's basically a different approach to how we take care of folks, instead of just sort of the churn and burn, having cogs in the machine producing widgets and selling a service for a specific price for however much quantity we can make of it. It's really about creating value by having the best quality at the appropriate cost, while giving everybody involved in it the experience that was needed. And beyond the financial part of that, I was intrigued by the interpersonal part that really makes value-based care successful and sets it apart from volume-based care. So those were the two things that got me started. And then, you know, I was reading Atul Gawande's book, Better, and it got me so excited about the whole concept of how we can, and it's not a value-based care book, but it's focused on how can we do healthcare better. And in it, he says, and I quote this in my book, but he says, you know, in the work against sickness, we begin not with genetic or cellular interactions, but with human ones. And I would add to that that also we don't begin with solely technical or technologic connections either. And the whole key, and one of the premises of value-based care, and I try and point this out in the book, is that the key is an appropriate application of relationship and technology. There are things that we can do and should do in today's world with the amount of data we can aggregate and analyze and know things about people, even sometimes before they know it. But if we don't have that relationship with a patient, and we don't continue to have a relationship with the patient, then they miss out on it, on really good care. They don't feel cared for. We don't learn everything we need to know about the patient, because you can't find everything in a discrete field of data.
You know, the interactions, not only between the doctors and the patients, have become transactional. The patients feel it too. You know, the patients feel like the doctor is being rushed. The doctor is more concerned about typing on the computer. The doctor is distracted with a phone call or a text message. They feel it too. You know, they feel that this system has become this way, but they got to fight for what they think is in their best interest.
Well, I dedicate a whole chapter to this in the book, actually, and it's called The Real Values in Value. And what I'm talking about with that is that when you think about the volume model and the volume equation, which is quantity times price, you know, that's what it is. Quality and experience aren't contemplated at all. And so when you approach something like that, again, where it's just and the medicine vernacular is treat and street, churn and burn, whatever you want to call it. When you approach it like that, you being the system, the healthcare system, does not value the components of healthcare. We don't value then the patients. We don't consider them humans. We consider them widgets. We don't value the staff or the physicians or the providers. We consider them cogs in the machine. And so that's one of the beauties of value-based care, is because we consider quality and experience, we have to value all the human element for truly what they are, and that is humans and worthy of what we have to offer.
Someone asked me, we had a social last night. And was it last night, Dr. Dan? What was it that someone asked about the difference between HMOs, capitated medicine from 1991 compared to what the world is like now today in capitated medicine in 2021? Dr. Hart, what would you say the main couple differences are?
Yeah, I think there's a few, and I think the folks that set out on the HMO journey had the right thing in mind. I mean, Mr. Kaiser, when he developed the healthcare program, on-site healthcare program for his folks in the shipyards in California, he had the right idea. And that's partly why Kaiser Permanente was the one, I mean, one of the few that survived the 90s and made it into this century. But I think the big difference between what we're trying to do now and the HMOs, that most of which ended up failing, is that we truly have the ability, and I spoke of it before, but it's that ability to aggregate a lot of data and look at it and to be able to risk stratify patients, to know who needs our attention most, so that we can then apply resources to them to optimize their health and well-being. What happened in the 90s, because we had paper charts and the inability, you know, we had the data, it was just in stacks and stacks of paper, and who could go through it? So what ended up happening with most of the HMOs is feeling the pressure to decrease cost without having the ability to truly analyze and do the basics of population health management, risk stratify, make a plan of care, and then longitudinally support those folks. They just went for care rationing and decided we're just going to cut costs by saying, no, you can't have that. And people didn't get along with that at all. And I think that's why it failed. And that's I think the key difference is that we now have that ability to take those stacks and stacks of data and information and make something useful out of it.
You know, Dr. Dan, in 1990, you switched your office to electronic health record. So you had the EMR in 1990. I want to know, what was that like, making that switch? And what was your relationship like with your patients, like with the paper charts? At the time of the paper charts, your relationship with the patients and your relationship with the emergency room doctors. And did you admit your own patients? I want to know what that was like, because what I'm trying to get at here is, yes, the data obviously helps. You know, of course, technology helps. It is an extension of us, and it makes our lives so much more efficient. But at that time, I have this kind of view of medicine from, at least in the 80s, of doctors really knowing each other well, knowing their patients well. If your patient went to the emergency room doctor or somebody would let their primary care doctor know. I kind of would like some insight around what that was like.
Well, I was at the University of Virginia then, and there wasn't there was a very nice emergency room, but the emergency medicine department was really in its infancy, and so it was basically people were managing their own patients. If they went to the emergency room, I would have to call one of the family medicine residents because I was part of the Department of Family Medicine, and they would go over to the emergency room and see the patient. And if the patient needed to get admitted, they would admit the patient to the hospital. And then certainly whenever they came back, and I would do my turn on the inpatient service and on the call. So yeah, we admitted our own patients. I mean, you said I put in an EMR. Well, I did. But you got to understand, that was before the internet. So I had an EMR that was not connected to anything. It was connected it was basically a way to keep records in the office, and it could give you reminders, on, you could have alerts when people needed flu shots and stuff like that. But as far as being tied to what was going on out in the real world, yeah, you still had to pick up the telephone. And still, one of the best pieces of technology I had was a fax machine. I thought I was in high cotton because I was able to buy a fax machine. And if a patient showed up to see me with chest pain and they'd been in the emergency room, I could call the ER and they could pull it out of their database and they could fax it to me, and I had an EKG to look at. So yeah. It wasn't a data-rich environment. But, I want to say one more thing about that. I'd be interested in what Jon thinks. I feel like when RVUs first came out, the idea was the RVU was going to be a byproduct of the care provided. And it was just a way to pay the bills for what was being done. And somewhere along the way, it got perverted to where what we're trying to produce is RVUs, not trying to produce health. And I think that's where things went askew. And I don't know how we get back to paying for health rather than paying for RVUs.
No, I totally agree with you, Dan. And I had one of those EMRs too, not hooked up to the internet in the 90s. And I think it's a key point to make about a change in medicine. And I don't want to sound like the guy who used to walk uphill to the hospital in snow 8 miles both ways, but we did communicate with physicians, with other physicians who took care of our patients. If you were going to send somebody to any kind of exologist, you would dictate a letter or call them on the phone. And lo and behold, when they saw that patient, they would call you on the phone, or if it wasn't particularly urgent, send you a letter back, and you actually knew what was going on. But in terms of RVUs, so, a relative value unit, I think you're right. It started out for the right reason, and it had has value as its middle name. It's really, I think, morphed into a relative volume unit and it became a tool of production. Tools of production work really well in a volume model. And so I think one of the ways that we can get away from running on the hamster wheel of fee-for-service medicine is to stop linking compensation to the productivity of relative value units, and start thinking more about truly member-based, and if you want to use the term capitation, fine, but member-based per member per month payments. That's direct primary care is based on that principle. Unfortunately, so is concierge medicine, and Faisel and I were talking the other day about how those unfortunately have gotten melded together. But I think that's some of the ways of getting away from that.
We should just call the RVU what the RVU is. It's reverse value. It is the reverse value unit.
Yes.
A good direction to go in is that the higher the RVU, the lower the value.
Well, it's one of those things too. So, a family doc or a general internist can spend 45, 50 minutes with a patient and generate, I think now it's 3, it used to be 2, but around 3 RVUs, or an ophthalmologist can spend 5 minutes with a patient plucking out a cataract and have 12 RVUs. So the math just doesn't add up. And I don't want to go down the debate of, well, the technology and the training of the ophthalmologist, justifies the cost. There's certainly justifiable cost in procedures, but tying it to these RVUs is not something I think is good. I wanted to share something with you guys that I finally took some files from home to my office this week, and my wife is thrilled. But as I was unloading them and stacking them in my file cabinet, I came across an article I'd saved from Arthur Kleinman from Harvard. He wrote this in 2012 for The Lancet, and it was The Art of Medicine, Caregiving as a Moral Experience. And I just want to read this part to you verbatim, because it really speaks to what we're trying to get at. And the general premise of his introduction is that, there are things that money can't buy.
Right.
And he said, many clinicians reflecting on what's at stake in healthcare, not only for patients, but for themselves, know the same thing. The market has an important role in healthcare financing and health systems reform, but it should not reach into those quintessentials of caregiving that speak to what is most deeply human in medicine and in living. This is the moral limit of an economic paradigm, or at least it should be. And he goes on to say, that the imperative that economic rationality gives to us on costs and maintaining efficiency have muted the moral and emotional and religious and aesthetic expressions of patients and caregivers. And I would go on to add too that instead of assisting us in our caregiving, we've allowed the incorporation of technology to participate in that muting as well, especially when it comes to discrete field data collection or in diagnostic testing. There are doctors today that, in addition to not having a conversive relationship with their patients, don't even touch their patients.
Oh, one of the things so when I joined ChenMed as a primary care doctor. And actually, Dr. Dan and I were just talking about this earlier today or yesterday, one of our random conversations about the feeling of the doctor-to-doctor patient relationship being restored with the full risk value-based care model. And I was asking you about earlier about the relationship that you all had especially like in the late 80s and that time period before the internet and before all this connectivity we had. Because when I joined the full risk model, suddenly the emergency room doctors were calling me, "Hey, your patient is here," or the hospitalist would call me. The specialists, we make partnerships with the specialists who have the best outcomes. And so when one of my patients is going to a specialist, I let the specialist know if I have a question. I give them a call, and just that relationship that I feel like used to be. When I think about what medicine ought to be like, it ought to be this world where we're able to communicate with each other in that manner, and even in the center too. For example, like I love knees and doing the steroid injections and working on knees, and in my center, the doctors, primary care doctors, the ones who weren't so comfortable with that would come with me, learn how to learn what I did. We had this relationship and this camaraderie, um, and I feel like that's the way it used to be like. And I wonder, could we have a model similar to what we have without all the data and technology? Of course, now I'm with obviously ChenMed. One of ChenMed's companies is an IT company, CTech. I mean, we're actually more of an IT company when I think about this more and more. We just happen to do primary care, but we definitely feel more like a tech company when I look at all the data that we crunch through. But what do you think? I mean, could we have a model like this? Could we? Is it really that simple?
I wasn't sure if you're asking me or Dan, but I'll jump in if Dan's going to hesitate. Yeah, I think it is possible, and again, I think the good news is that technology actually affords us better opportunities to communicate with each other as physicians than what we had when we had to pick up the phone, and hopefully when I tried to call Dan, he wasn't in the room with a patient. But now we can communicate asynchronously and securely, and or we can pop up. If I were in a room with a patient, I needed them to see Dr. Dan, I could pop him up on telemed and he could join in, and we could have a conversation right there. So technology can really be an assistant, a valuable assistant in that, because if you're going to have a relationship with the patient, not only does the primary care doc have to initiate and nurture that relationship, but as you bring more people into the interdisciplinary team to take care of that patient, communication becomes even a more important linchpin in that relationship. And so people talk about hypersegmentation in healthcare, and boy, wouldn't it be better if we could get everybody just to hyper specialize and take, then everyone could have a specific doctor for a specific problem. And I don't think that's a bad thing, but we've been doing that for 100 years. And what we've seen in the recent past is this separation in relationship from physician to physician, so that then the patient gets left in the middle to fend for themselves.
Yeah, well, and that would be sort of like trying to build a house. An analogy I use is when you build a house, you almost always have to have a general contractor to do the construction. You don't just go out and hire an electrician and a electrician and a rough carpenter and a finish carpenter and a brick mason and tell them, hey, I need a house at this location. Can you all show up and build it for me? Because it takes the coordination of care. And the interesting thing is, if you've ever built a house, is if you walk on a job, the subs won't talk to you if you're not with the general contractor, because the general contractor is the one that's coordinating everything, and they know they're just going to get in trouble if the client asks for something. Yet in healthcare, there is a lot of incoordination taking place, a lot of waste, and honestly, a lot of harm that comes from that incoordination. But I don't know how we get to that point but I think the other thing is the contractor actually gets rewarded for the value of the finished product at the end. They're not just paid for their time standing there talking to the subs. They're actually paid for the final product. And I think that's what you're talking about when you start talking about capitated payments for primary care. You're actually being rewarded for the finished product, the healthy days you're giving the patient.
Yeah, and I think I think philosophically we need to be sure that we separate the financial aspects of a solid physician-patient relationship from the personal and human aspects of that relationship, because I do think if we can think of the patient not as a disease but as a person, then we're going to be more intentional about our communication, not only to them, but then to anybody else that we engage on the team. And, I quote a couple of different Williams in my book, and one was William Osler, and he said that, physicians should care, let's see if I can say it right, care more particularly for the individual patient than for the special features of the disease. And then William Carlos Williams, who I love as a poet, he said that, people come to see a physician, and the people that come to see a physician are not merely hearts or livers or kidneys. They're a person with a unique problem. And frankly, we can't figure out what that unique problem is until we have that relationship and ask the questions. I see so many software platforms that try to say, well, we can tell you everything about this patient, including all of their social risks based upon an analysis of social determinants of health and their claims data and their pharmacy data and everything like that. But you know what? You may not know that Mr. Jones doesn't have reliable transportation or a reliable food source until you actually ask him the question. And then, Dan, to your point, then when I know that about Mr. Jones, I'm gonna take a whole lot more intention and effort in communicating things to the other people on the team so that they know Mr. Jones is a valued friend of mine. I have a relationship with him. I expect you to treat him the same way, and you're going to keep me in the loop so that we can all do what's best for Mr. Jones.
Well, and I think that's the important part. I mean, one of my mentors coming along would say, people want to know how much you care before they care how much you know. But I think,
Yeah, right.
I don't you think that the specialists, for the most part, they appreciate somebody who cares for the patient, and if they see the PCP has time to care and interact with them, they like being part of that as well.
They do, and the specialists that we bring into our preferred provider network with Millennium Physician Group, we encourage them to use our care management teams and social work teams, and our PCPs are supported by an interdisciplinary team around them so that the physician doesn't have to solve every problem. In fact, the physician may not even uncover every problem, but they know that they have somebody to help them with it. And I think, to your point, Dan, the specialists are thrilled if they know that, okay, if I send this patient back to Dr. Dan, he's going to help make sure that they can afford their medicine, that they're going to get it, and that if they can get to the next appointment, and that their housing is secure, and and so that they don't have to worry about that because they know that you're taking care of it.
We have a question here.
Go ahead.
Let me put it up here. All right, from Asad Kazmi. Thank you. So we have a question for Dr. Hart. How important is the doctor's attitude over expertise in the satisfaction of their patients?
Oh, I think it's huge. When I was in residency, and this was 30 years ago, there was a doctor in our hospital. He was a family doc. He still saw his patients in the hospital, and this was a tertiary care center. And he had more patients in the community than anybody else. But frankly, we all felt like he was a bad clinician in terms of the things that he did. But his patients loved him and would do anything that he thought they should do because his attitude was one of, I'm present with you in the room. There's nothing more I care about than what's happening right now. And you're the most important person that I'm going to see today. And I'm going to make sure that I do everything in my power to help make you feel better. And so in a way, even though his clinical acumen was not necessarily where we, as residents thought it should be, he was actually a pretty good doctor because of the attitude that he approached his patients with. And the good news, he knew when to ask for help too. And so that's sort of an extreme example. But then if you can take a doctor like Faisel, who knows his stuff, and then presents an attitude of, yeah, there you go, and presents an attitude of, I'm present with you, I'm helping you feel cared for, you're the most important thing that's going on right now, then that's going to be a successful interaction with the patient. And we also, the medical literature for years has been saying that if you can help allow a patient to feel cared for, your clinical outcomes are going to be better too. So actually, you also get, you're a better doctor in practice too, because your patients do better.
It's definitely much more fulfilling. It's definitely a much more fulfilling way to live your life. And I have an example, when you're mentioning about the technology with a patient, a new patient visit, I had as a telemedicine visit. So this was early on in COVID. We had just switched from, we see our patients on a monthly basis. The patients get a weekly phone call that we call a love call. They get a daily text message. So we're
I love that, by the way. That's
yeah,
awesome.
it's a high touch model, and so we switched to telehealth, and we have clinic, and we're doing these telehealth and telemedicine visits. And I had a 57-year-old. So we're full risk Medicare Advantage, but we have like 15% of our patients are under the age of 65, the dual eligibles, And so I had a 57-year-old a new patient visit at an alcohol treatment facility. And it was his first it was his first FaceTime. It was his first FaceTime type call. Well, he had an experience like that before. So I thought, okay, this is gonna be interesting. I've never done this before. I never have established a new patient at an alcohol treatment facility,
Yeah.
But I went along and had the encounter, and the patient was just so blown away that I had my lab coat, I had my stethoscope all around my neck, although I wasn't going to use it, telehealth visit, but he was blown away that here I am establishing him, and we're talking over this, over the face. I call it FaceTime, but the telemedicine,
Right. Yeah.
And so we were just getting to know each other. Right away he started off saying, "I need my Xanax. I need to refill my Xanax." And I have to go to the emergency room once a month because he struggles with homelessness. So he struggles with homelessness, and his Xanax gets misplaced or it gets stolen. And he just started off the conversation saying that he needed his Xanax refilled. And then I heard him saying that how he has to go to the emergency room once every month to get it refilled. And I said, well, why do you have to go to the emergency room once every month to get it refilled? He said, well, the pharmacy gives me a 90-day supply at a time. And because I misplace them so frequently, I have to wait the 90 days. So rather than waiting 90 days, I Baker Act myself. And then I go to the emergency room until somebody will give me my Xanax. And I thought, boy, and then he said, the funny thing, Doc, it's not even spelled Xanax. It's spelled Zoloft. And I thought, well, it's funny, but it's a reality of the world that we're in, right? And I had to tell him that, hey, that's not Xanax that you're taking. That's like if you were taking like a blood pressure pill for your blood pressure, that is like a pill that you take for depression and anxiety. And actually, it was a very low dose Zoloft. It was like 25 milligrams. Mm-hmm. And the shock on his face, he said, you mean to tell me that's not Xanax? And I said, no, it's not Xanax. I told him, I said, listen, if you ever lose your Zoloft or someone steals it, you just call me. Here's my cell phone number. I gave him my cell phone number. I said, you call me and I'll buy it for you. It's one of those medicines that you can get for $10 for cash price from Walmart for 3 months supply. I'll buy it for you. Mm-hmm. And you know what he said? He said, Dr. Syed, I don't want anything to happen to your medical license. He was worried about me. And now this is someone that we have two very different lives, and we're engaging for the first time like this, with the video. We're not in person. And that doctor-patient relationship happened. Suddenly
you treated him like a human.
Yeah. And now it's almost a year later, and he hasn't been to the emergency room since. Now, am I someone who knows about psychiatry or No, I'm not an expert on psychiatry, psychology. I know enough, but that's what I'm trying to say. It's not the pathophysiology. That's not what drives all the waste in America. It is this. It's that, like the patients who don't understand. I mean, if you look at the average 72-year-old, our average patient is 72, 74 years old. That means that they graduated from high school in the 1960s. And if you look at 1970, the percent of Americans who had a college education in 1970, only 12% of Caucasian men had a college education, like a 4-year college degree in 1970. And then the number drops in half for African American males. And then it goes a little bit lower to white females, and then the black females even lower than that. So the population of patients that we have, we can't approach them thinking that just when you're just thinking about health literacy alone. We can't approach talking with them as if we're talking to a medical student or a nurse.
Right.
And I feel that if we focus on the person, and we can reduce so much of the waste in the country, just if we just focus on the human being that's sitting right in front of you, rather than having to be concerned about filling the fluff in the chart to get your 9921 whatever.
Mm-hmm. No, I totally agree with you. Absolutely. And you talk about the waste. So your fellow that you've kept out of the emergency department for the last 11 months, you saved probably the payer, because I'm assuming he was a dual eligible.
Yeah.
So you saved the payer, probably, somewhere between $12,000 and $20,000, which if we could do that in all the areas where we have the waste, we'd have so much more money left over to take care of issues like homelessness and education and healthcare for people who don't have it. It all comes back to, are you going to create value when you have that conversation with the patient, or are you just going to churn the volume out? And if we keep with the fee for service, I don't want to sound Chicken Little about it, but I think that's going to be the demise of our healthcare system if we can't get the primary care docs to sort of lead the way into a value system that values the components of that system. And by that, I mean the patients, the staff, the providers, everybody, and that we aim for quality, we aim for experience and appropriate cost. Without that, I do think it's going to implode.
Oh, it's already the system itself, and just the impact on society. I'm appalled that the number one cause of bankruptcy in America is medical debt. And it's medical debt from the hospitals. It's not medical debt from the primary care doctor or from the radiology place doing the mammogram. It's from these unnecessary hospitalizations. And just the amount of Americans who are in debt collection, period. 1 in 5 Americans in debt collection is ridiculous because of medical billing.
And like most problems, the solution is both simple and complex. Because when we've been talking about it like it's really simple to have this great communicative and relationship with the patient and with other people on the interdisciplinary team and collaborate with all that. It's a very simple answer, but it's complex to carry out. And I do think that's where we need to rely on technology to help us bridge those, some of those gaps. But we still have to maintain the relationship with the patient.
Yeah, and you'd think that with the elderly that they'd be opposed to telehealth, telemedicine, and that's not the case. That's not the case. The thing I find so fascinating is how you become part of a special group of people, because many of the seniors, they don't even FaceTime their own children, but they will FaceTime their grandchildren.
That's what I was just thinking. Thank God for grandchildren, because that's what's, then they'll talk to the doc because they'll talk to their grandson. Yeah.
So suddenly when I have the telehealth visit with my patients, especially my seniors, I have now gotten indoctrinated into this special club. And I see here Chris has a question here about the lens into the patient's home. This is great. Chris, I have to tell you, one of the most amazing things about doing telehealth, and especially with geriatric care, is just how when our patient population gets comfortable with their primary care doctor, it's a beautiful relationship. But they'll tell me the diabetic will tell me they're not drinking soda, and then they'll go to shop. Well, let me show you the fridge, and they open the fridge, and sure enough, there's like there are cans of Coke in the fridge. There's juices and things that shouldn't be in that fridge. But I would never have been able to see that. I never even thought about being able to see that in a patient's home up until now.
Yeah, well, because you're not old like Dr. Dan and me, where we actually did house calls and we're physically in the home. And I remember, going and seeing patients, and the granddaughter of the patient would be whipping up big Cathead biscuits in the frying pan for me to eat later. But I think it's a great point to be made, and that is that so much valuable information can come from being in the home, and even if that's in a video thing, because to your point, you can say, hey, show me what's in the fridge. Bring your box of medicines. Let's look at this box of medicines.
Absolutely.
Show me the floor of your house. I want to see, are there rugs, are there things that are, or did that little yippy dog that was barking in there while you're trying to talk to the patient, is that a trip risk? So you learn all those things. I think that's a great point that was made.
I feel like just efficiency of care in general. If you had doctors focused on doctoring, like you have primary care doctor doing real primary care, I feel for something like we were talking earlier about the knee pain, for the orthopedic surgeons who are looking at a knee pain that wasn't properly managed from the primary care doctor because of whatever reason. Oftentimes it's because they just didn't have the time. I know that they could handle that situation, but when you have specialists doing primary care work but getting reimbursed at the specialty rate, it's a pity. What a shame. What a waste. And so when you have doctors, like you have the primary care doctor, allow the primary care doctor to practice to their full scope of being a family physician or an internist, to reduce the unnecessary specialty referrals. And then also, America's a young country. The average American's only 37 years old. I just read that there are somewhere like now 150,000 nurse practitioners in America, 200,000 primary care doctors. With the technology and now with the nurse practitioners and the physician assistants, I mean, we're talking about if we had a culture of prevention, we've got the teams already in place. And the country is a young country. Average American's only 37 years old. I just feel like the technology exists. We have the drive. Perhaps people just need to see like places like doctors like us in this full risk world just really just scaling out, and hey, it's doable. Come learn, try to do it yourself. If not, please come join us.
Yep, totally agree.
Well, Dr. Hart, thank you so much for a great evening. We went a little bit over. I'm sorry. I want to try to keep it to 30 minutes, but sometimes you just can't, And I appreciate you for coming on tonight. It was a lot of fun with the KRS One panel. We were both on the KRS One panel just a couple weeks ago. And we didn't even make it through halfway through our slides.
Yeah, no, I between the two of us, we're a couple of gabbers, and so we a half hour is not near enough time hardly to say hello. So,
well,
but no, I appreciate being on here, and I'm still so appreciative of you pre-reading my book and making a comment that we put on the cover, and just thrilled about that, and always would welcome further conversation about value in healthcare and the patient-physician relationship and everything that goes into that.
Absolutely. And Dr. Dan, thank you again.
Absolutely.
Your internet didn't go out. There's an ice storm happening in Richmond, Virginia, and I was ready for the internet to go out. And I must say, what a pleasure it is for us to be able to just talk shop, talk about value-based care. We're three doctors in different parts of the country. Dr. Hart and I are pretty close together, but just being able to talk about how we have a model, we have a way where you can restore the doctor-patient relationship You can restore the doctor-to-doctor relationship and just move away from this nonsense hospital-driven system. So thank you so much. This is really Dr. Dan's. If it wasn't for Dr. Dan, I would not be doing this stuff on social media.
We appreciate you, Dan.
Absolutely. It's great to be here with you. And I think just, talking about the doctor-patient relationship and restoring the sanctity to that is just, that's where we all need to get to, is doing what's right for the patients.
Yes, sir.
Well, thank you. And to our audience, thank you so much for participating. We love the questions. We love the comments. Thank you so much for joining us this evening. Sorry we went a little bit over. We're trying to keep this from 8 to 8:30, but sometimes you just can't help it. For more information about today's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We're on track to open another 500 centers across the country. That means we need about 2,000 doctors, bunch of nurses, bunch of staff. We believe access to primary care is a right, not a privilege.